So we're gonna discuss tetralogy fellow uh, today. Okay, so tetralogy fellow has been in the news recently. Plus, it's very testable. You will definitely get this in your exams, and you're going to see a lot of patients coming to the lab who have had repair of their tetralogy fellow. So getting familiar with and knowing about tetralogy fellow is important. So the topic is tetralogy fellow. Fellow is a French word. Tetra means four, so it's four things that's going on. Hello? So you guys can't hear me clearly? What about now? Can everybody hear clear?
No, there's a lot of static.
A lot of static. Wow. Okay, let's. We're gonna do tetralogy fellow. As mentioned before, tetralogy fellow has been in the news recently. So there's a lot of buzz about tetralogy fellow, and you know you're gonna in the echo lab you're gonna see a lot of cases, a lot of patients who have had repair of their tetralogy fellow. So as the name suggests, tetralogy, tetra means four. So it's four things that's happening. Four things. So you have to remember that. There's also a pentalogy of fellow, but the common one is tetralogy of fellow. And the four things is pulmonary infundibular stenosis. Okay? So therefore you have an obstruction at the right ventricular flow tract. You can also have obstruction there. You can have obstruction lower down in the pulmonary circuit. So you can have obstruction at the branch pulmonary arteries. The next thing is your overriding aorta. You have a ventricular septal defect and right ventricular hypertrophy. So those are the four things that make up tetralogy fellow. Pulmonary infundibular stenosis, overriding aorta, ventricular septal defect, and right ventricular hypertrophy. So if you sit back and you think about it a little bit, you have obstruction at the right ventricular flow tract. So that's going to give rise to your right ventricular hypertrophy because blood is trying to get out of the right ventricle. The right ventricle is going to have to work harder. So you get right ventricular hypertrophy. And one of the congenital defect is a ventricular septal defect, and the aorta sort of sits over the VSD. So those are the defects. When you have a pentalogy fellow, it's usually a ASD. So in addition to these four features, you have a ASD, atrial septal defect. One of the determinants, the main determinants to repair what's going on is the obstruction, the amount of obstruction you have in the right ventricular flow tract. So if you have, the worst obstruction you could have is pulmonary atresia. There's almost no blood going into the pulmonary circuit. So atresia means failure to develop. Okay, so that's the extreme case. If you have that extreme case, you have to operate because there's no blood going into the pulmonary circuit. So you're going to have to divert blood from wherever and put it into the pulmonary circuit. So that is the concept. You have to get blood into the pulmonary circuit. And we'll talk about shunts. So you're going to shunt blood from some place into the pulmonary circuit. All right, so if you just look at your normal heart, of course, you have your intact ventricular septum. You have your your right ventricular flow tract, your pulmonic valves, and your pulmonary circuit, main pulmonary trunk. You have the right and the left main pulmonary arteries. Okay, when you have, and you can see the thickness of the RV wall. This is the thickness of the RV wall. So when you have tetralogy of Fallot, you have a ventricular septal defect, a defect in the ventricular septum. The aorta now overrides the VSD. Remember, your aorta is right here coming out of the left ventricle. When you have tetralogy of Fallot, now your aorta overrides the ventricular septal defect. Because you have obstruction to the right ventricular flow tract, and you may have obstruction, some of the branches of the pulmonary artery. Okay, obstruction, the right ventricle is going to work harder, so it's hypertrophed. It gets thickens. So that's tetralogy of Fallot. So what are some of the signs and symptoms of tetralogy of Fallot? How the patient is going to present? One of the things, the baby, if it's significant, they're going to present as a baby. And low oxygen saturation. So you do your pulse ox or whatever oxygen saturation method you use. Low oxygen saturation. Baby may become cyanotic. Okay, because especially if you have significant right ventricular flow tract obstruction, then the deoxygenated blood is going to mix with the systemic circulation, and they're going to present with cyanosis. Going to look blue. Failure to thrive, decreased growth, okay? Shortness of breath, dyspnea, digital clubbing. So when you look at the fingers and the toe, there's a swelling at the tip. That's what we call clubbing. There's a swelling at the tip of the fingers and toe, and that's evident, okay? Polycythemia. Polycythemia means increased red blood cell volume. And that is because of the hypoxia. One of the stimulus to polycythemia, increased red cell growth, is decreased oxygen. So once the bone marrow perceives that there is decreased oxygen saturation in the blood, it's going to try and compensate for that by making more red blood cell. So that's polycythemia. So when you do your echo, what are the things that you're going to see? So you will see your VSD. You can see that. You can see right ventricular hypertrophy. You can see that. You can determine how much right ventricular flow tract obstruction you have. Because remember, the main indication to take these patients to surgery is the amount of right ventricular flow tract obstruction. So you have to determine the degree of right ventricular flow tract obstruction. And you have to look at your Doppler, see if there's branch pulmonary artery stenosis or there's pulmonary insufficiency. So when the patient comes to you and they have had repair, if they had repair, more than likely you're not going to see a VSD, or you might have a remnant of a VSD. They probably still have some degree of RVH, but the obstruction will be because one of the approach is to relieve the obstruction. So you might not see significant obstruction. all right? But there may still be some amount of obstruction. Remember what we always talk about. If you're going to determine pulmonary hypertension, then, as we have said over and over before, when you calculate your right ventricular systolic pressure, it is equal to the pulmonary artery systolic pressure if there is no obstruction at the right ventricular flow tract. If there is obstruction at the right ventricular flow tract, then that does not hold through anymore. So if you have obstruction at the right ventricular flow tract, your right ventricular systolic pressure is not equal to your pulmonary artery systolic pressure. So you cannot just calculate your right ventricular systolic pressure and call that your pulmonary pressures. No, you can't do that. What you have to do is calculate the gradient, or calculate the gradient across the right ventricle, the gradient across the tricuspid valve, and you're going to subtract from that the gradient across the right ventricular flow tract, and that will give you the pulmonary pressures. It's very important to do that, because if you don't, you're going to falsely give the patient pulmonary hypertension. Okay, so short axis at the level of the aorta. Of course, this is your aorta, and this would be your right ventricular flow tract. You can see that there's hypertrophy. If you look at, you say thickening of the right ventricular wall. So there's some obstruction right there. Okay, there's some obstruction. Okay, so you have to relieve. One of the things is to relieve that obstruction. So when you do your, and you know, a lot of you guys are not going to see someone coming to the echo unless you do pediatric, and not only pediatric, but you have to do probably neonatal. You have to do fetal echo, because you're gonna see these defects in utero. So you're definitely gonna prepare. As soon as the baby come out, you're gonna determine, should the baby go to surgery right now, or you're gonna wait. So a lot of you guys not gonna see the baby looking like this. So this is your ventricular septum right there. This is your VSD. Your overriding aorta is right there. Overriding aorta. You can see some evidence of right ventricular hypertrophy. Okay. So right ventricular hypertrophy, right ventricular flow tract obstruction, VSD, and your overriding aorta. Okay. So if you do neonatal or fetal echo, then you will see this. Usually, if you're going to do adult echo, you're going to see the patient have to repair. So, other defects that you can get with tetralogy of Fallot, you can get branch pulmonary stenosis, and the left pulmonary artery will be involved in about 40% of the case. So not because you have right ventricular flow tract obstruction, you're going to think that, yeah, that's it. You have to look for stenosis further down. So we talk about branch pulmonary stenosis, 40% of the left pulmonary artery. Bicuspid pulmonary valve in 60% of these individuals. So bicuspid pulmonary valve. Right side of the aortic arch, 25%. Coronary anomaly, so anomalous coronary blood vessels. So the right coronary artery may come from the left. So ASD or PFO, so that's what we'll talk about, the pentology of a low, atrial septal defect or PFO. Atrioventricular septal defect, anomalous pulmonary venous connection. So we discuss anomalous pulmonary venous return. So it may be partial or total, as we have discussed before, and scoliosis, which is a skeletal problem. So let's okay. So we gonna there's some